You guys really seem to like my last video on reviewing all of my Anki cards for the past month, and so I thought I would do it again. And just to reiterate that it's all about consistency. So every time you're in the hospital, write down on the back of your patient list or somewhere in a journal where you can keep track of all of the little pearls that you learn from day to day, and then later you can turn them into Anki cards. And it looks like over the past month I've made about 100 Anki cards, which is a little bit higher than normal. But over the course of an entire month, that really doesn't cause you to have that many reviews. On average, I've probably been doing about 30 to 40 cards a day, which takes about 5 to 10 minutes. It's very short. And so that's really when you get the power of Anki. So let's start this custom study session now. And here we go. So is it okay to give PO medications in a patient with an NG tube on suction for bowel obstruction? The answer is yes, but of course your absorption may be unclear. So for essential medications, try to convert to IV to ensure adequate effect. What diagnosis should you consider in a patient with high ammonia and worsening mental status with no underlying liver disease? So this is very rare, but it was on the clinical problem solvers. And so it's something to keep in mind because generally we don't check ammonia in these patients. Hepatic encephalopathy is a clinical diagnosis, not one that's based on the ammonia being high or low, because ammonia can be high and you cannot have hepatic encephalopathy. And vice versa, it could also be low and you can have hepatic encephalopathy. But there are some rare diagnoses that you could want to be aware of, and there is a potential that a patient could have a urea cycle disorder. Now, typically you think of these presenting in young children, but it is possible to have late onset urea cycle disorders if there is a significant stressor, infection, or inflammation. So in somebody who has really unclear reason for their altered mental status, and they have a very high ammonia when somebody checked it, it is something to consider. That's probably pretty rare and not super high yield, but it's something interesting. And, when you're going through all these clinical problem solving exercises, it's definitely an interesting fact to know as well. When should you start a camprosite after acute alcohol withdrawal? Typically, after 5 to 10 days of abstinence is recommended, but from a practicality standpoint, it can be okay to just start it on the day of discharge, and it becomes therapeutic in about 5 to 8 days. How can an increase in MAP help you determine if a patient with hepatorenal syndrome will respond to terlipressin? This would be an increase in the MAP of greater than 10, and generally this is pretty immediate after you start terlipressin, so within 5 minutes. And if this increases by 10, this indicates patient will most likely respond in most studies. So I recently learned about this at the SHM conference where there was this terlipressin rep going around and telling us about some of the nice learning pearls about this medication. Epilepsy surgery evaluation should be considered after failing how many anti-seizure medications? That would be after failing 2 medications. And you have 2 approaches, a destructive approach, which is with resection or laser ablation, which can be potentially curative, or palliative approach with stimulation devices, VNS, RNS, DBS. I only know what DBS is. I'd have to look up what the other ones are, but those are also options. And so the reason I have this card in here is because we recently had non-medicine for the hospitalist talks. And so we had some neurologists come in and talk to us about stroke management, seizure management, and then also some surgeons come talk to us about bowel obstruction management and pressure ulcer management. Should you make sure KUBs are obtained upright to assess for suspected small bowel obstruction? The answer is yes, because it helps you identify air fluid levels. What is the term for unexpected death in patients with seizures? There's a term called SUDEP, which is a sudden unexpected death in epilepsy. The risk is 1 in 1,000, but it increases to 1 in 100 in patients with intractable seizures. What size NG tube is recommended for a small bowel obstruction? And the answer to this is basically the largest tube that you can get. So 18 French. So you'd prefer this over the 14 French because that tends to be just more for feeding, and a smaller tube is more likely to get clogged than a larger tube. Are small bowel obstructions or large bowel obstructions more likely to need surgical management? According to the surgeon, large bowel obstructions are more likely to need surgical management. The colon can tolerate less than a small bowel obstruction can. Also, it kind of becomes this closed loop obstruction because the ileocecal valve kind of functions as a one-way valve. And then if you have obstruction distally, you have basically both sides are blocked off. And so imagine the amount of pressure that's going to start building in that kind of obstruction. Whereas with a small bowel obstruction, even if you have a obstruction down lower, at least you know that upwards through the esophagus, vomiting, things like that, at least that side is open. So that can kind of be a pressure outlet in some senses. So LBO is much more often surgical and should be approached with more urgency. Is postrenal or obstructive AKI more likely to cause hyperkalemia compared to other etiologies? And the answer is yes, because in obstructive AKI, you have complete blockage of all your nephrons, so no potassium can be eliminated. Whereas if you have an intrarenal AKI, for example, from ATN, you still have some functioning nephrons, and so you're still going to be able to excrete some potassium in those scenarios. Alcohol can lead to lactic acidosis due to increased production of what substance? This is going to be NADH, and I'm actually going to make a video about this soon, but there was this great talk at the SHM conference talking about the real, the best way to approach lactic acidosis. And they basically went through all of the biochemical pathway. Anyways, it was a really good talk, and you'll see the video when it comes out. What is the best positioning for reducing an abdominal hernia? Apparently, if you put them in Trendelenburg, this can help you be more successful reducing it. And also consider giving some Versed, as it may be uncomfortable. What should you think about if a patient has sinus tachycardia with elevated blood pressure? The answer to this is sympathetic overdrive. So sinus tachycardia typically is there to prevent hypotension, but if you have somebody who's hypertensive and tachycardic, then you want to think about sympathetic overdrive from endogenous sources, hyperthyroidism, catecholamines, or exogenous substances like beta agonists, cocaine, methamphetamine, stimulants, and things like that. How can you differentiate ileus versus Ogilvy's in terms of what parts of the bowel are distended? So ileus is going to be your entire bowel is distended, and Ogilvy's is just going to be involving the colon. And Ogilvy's tends to be in a sicker population. What kind of special PET CT scan can you get to evaluate for neuroendocrine tumors? The answer to that is a PET dotatate study, which is something I'd never heard of until last week, but this identifies cells that express somatostatin receptors. Should you cross-titrate when switching a patient from an SSRI to an SNRI? Generally, yes, and slow cross-titration over 1 to 2 weeks is typically recommended. So we had a patient who was on an SSRI. They were in the hospital for chronic debilitating cancer pain, and I wanted to switch them to an SNRI to get some of that neuropathic pain benefit. And so this issue came up, and we cross-titrated them successfully. How long do you have to be seizure-free to have your license restored? Apparently, this is about 3 to 6 months, and only 6 states have mandatory reporting. California is one of them. Other states are actually self-reporting, which is kind of concerning. If somebody has a seizure, they self-report to the DMV. What if they don't self-report? That is a little concerning. So very interesting. But also interesting thing to note is if you have hypoglycemic syncope, PNES, cardiogenic syncope, these should actually all be reported to the DMV because these are all risks for them syncopizing while they're driving. Will a patient having an active seizure withdraw to pain? The answer is no. So if somebody seems to have jerking movements, they're altered, and then you test for noxious stimuli and they withdraw, that would be not consistent with a seizure. And so it can be one way to help you differentiate if it's a true seizure or not. Why does cryptococcal meningitis lead to increased intracranial pressure? So the reason is because the polysaccharide capsule of the cryptococcal organism obstructs the arachnoid villi, which basically prevents absorption of CSF and increases the viscosity of CSF, making it thicker and more resistant to flow. So prevents absorption. Long-term consequences and brain injury start to occur if seizures last longer than how long? That's going to be greater than 30 minutes. And so this is a helpful figure to know. And we do know that you get cortical necrosis as you start having prolonged status epilepticus. So very important to abort these seizures as soon as you can once it's getting past 5 minutes. How long does it take to deplete folate stores? This is just a quick reminder, but just a few weeks, whereas B12 deficiency takes years. Is gas expected in a patient with chronic open stage 4 pressure ulcer? This is something that's always very concerning to the internist because we get this chronic pressure ulcer patients and there's gas all over the place and on imaging, and it's very concerning. And we're like, is there some kind of necrotizing infection here? Apparently, it is very common to see gas in these patients because it's just open. And I've heard surgeons say that before, but it's nice to have confirmation that, again, this is something they see commonly. And then CT showing osteomyelitis is also pretty common. What trial demonstrated that clopidogrel monotherapy was superior to aspirin monotherapy for stroke? This was the I forget what the name was, Capri trial. And so this is why our standard of care is after a stroke, you start them on the dual antiplatelet therapy. Typically that's for like 21 days if they are a candidate for dual antiplatelet, and then you switch them to preferably Plavix over aspirin. What is the main cause of anal fissures? This is constipation. Usually this causes posterior anal fissures. If you see anterior or lateral anal fissures, you should consider some systemic issues. For example, IBD could be a cause of something that looks like a fissure, but actually is some kind of like sinus tract or fixed fistula that's causing that instead. What is the term for how natural killer T cells induce apoptosis in cells? This is antibody-dependent cellular toxicity. And this is something that I learned while I was on my hem-onc rotation. Just interesting to know the mechanism for, or actually the official terminology for how it releases those granzymes and everything and causes apoptosis. Is paracoccidiomycosis more common in males compared to females? The answer is yes, because estrogen appears to have a protective effect. And if it's in a tropical humid area, this should increase your suspicion for paracoccidiomycosis. What is a useful topical treatment for severe malodorous discharge from chronic wounds? That would be 0.75% topical metronidazole daily. Do most adhesive small bowel obstructions resolve within 24 to 48 hours? The answer is yes. What is the doubling time of most lung cancers? Does it double in a few weeks? Does it double in a few months or a year? The answer is about 5 to 6 months. Is passing gas or having a bowel movement a more reliable indicator of improving bowel function after obstruction? So according to the surgeon that was lecturing us, passing gas is a much more reliable indicator about their bowel function, because if they have a bowel movement, it's possible that those contents were already just near the rectum, but if they're persistently passing gas, that's a much more reassuring sign for them. Is terlipressin less effective if creatinine is greater than 5? The answer is yes. So the earlier you can start terlipressin for hepatorenal syndrome, the better. Per the studies, at a creatinine of greater than 5, it was essentially no better than placebo. Beta-2 activation, such as albuterol and epinephrine, can lead to lactic acidosis due to increased production of what substance? This would be pyruvate. Again, we'll talk about this in the video I'm hoping to do in the next few weeks. What term is starting to be favored over compensated and decompensated cirrhosis? That would be clinically significant portal hypertension versus non-clinically significant portal hypertension. I know, all the GI, GI just keeps making all these name changes. NASH, now we're calling it MASH. NAFLD is now MASLD. Now we're getting clinically significant portal hypertension, non-clinically significant. Neuro is doing it too. Everybody's just changing all the things. So apparently focal aware seizures, it used to be called simple and partial seizures, and then it became focal seizures with impaired awareness and intact awareness, and now it's becoming preserved consciousness, non-preserved consciousness. Apparently this just happened a few weeks ago. So everybody's just changing the terminology all the time. Should you avoid terlipressin in a patient satting less than 90%? The answer is yes. Avoid in hypoxemic patients with volume overload due to the risk of pulmonary edema. Also avoid in pregnant patients due to vasoconstriction and patients who are high on the transplant list, because this may drop their MELD and subsequently their priority on the transplant list. Is Zyprexa or Haldol preferred for acute agitation with aggressive behaviors? The answer is Haldol. Was speaking with psychiatry and they had ordered Haldol and I wasn't sure why. I asked them and they said for acute agitation with like violent behaviors, Haldol is typically preferred. Is a patient with HRS and multi-organ failure more or less likely to respond to terlipressin? I know it's a lot of terlipressin overload right here, but I learned a lot from that talk. And so if they have multi-organ failure, they are less likely to respond to terlipressin, and this is based on the CONFIRM trial. What is the difference between an incarcerated hernia and a strangulated hernia? Back all the way to medical school. So remember, incarcerated hernia just means it's non-reducible, but if it's strangulated, that's when it's starting to actually have ischemia. What are 2 important questions to ask a patient with a history of seizures? So the important questions to ask are the frequency of the seizures and then what their baseline seizure looks like. So frequency, it's important to know if they're having it very rarely or multiple daily, because if they're inpatient and you're having it multiple times a day, you need to know if this is a change or if this is just their baseline. And then also knowing what the baseline looks like is useful to know when you should be concerned as well. Why is it possible to have a late onset presentation of a urea cycle disorder, maybe triggered by stressor, infection, or inflammation? What are risk factors for developing seizures as an adult? This is going to be premature birth history, history of febrile seizures, trauma in the past, or brain tumor. Basically, these are all risk factors. What is a way to test for upper and lower extremity weakness in a patient who is not following commands? This is something that we come into a lot, and there's patients who get delirious in the hospital. They're not following commands, and now you don't know if they had a stroke. They're like not moving extremity per nursing, so you don't know how to test them. So one of the ways is actually just do passive arm and leg raise and see if they're able to hold it up or keep it there. That can give you some sense if they have strength in that extremity versus if it just like flops down completely flaccid. Is induction therapy used for treatment of newly diagnosed CML? Well, per my recent leukemia versus lymphoma video, you know that the chronic leukemias tend to have a less aggressive treatment course. And so no, we use instead oral tyrosine kinase inhibitors like dasatinib, imatinib, and ponatinib. What does a positive C. diff toxin on a GI panel but negative on C. diff diagnostic indicate? So we had this biofire come back that was positive C. diff toxin, and then we sent off a C. diff diagnostic test, and that one was negative. So what does that mean? So this means the patient is colonized with C. diff Clostridium that can produce the toxin, but they're not actively producing the toxin. So no treatment is indicated. What is the first branch point when evaluating fever in a returning traveler? So the first thing you need to consider whenever you're presented in a morning report case or in real life about fever in a returning traveler is don't anchor yourself to that fever and the travel. Remember to assess first if it's travel related or travel unrelated. Base rate of disease, it's more likely that's going to be some travel unrelated cause of their infection because those are much more common, a common viral upper respiratory infection or some gastroenteritis. Those are much more common causes compared to esoteric things like, Zika, rickettsia, Q fever, all these random things that could be considered in a patient with travel. Anti-epileptic drugs should be started if seizure risk is greater than how much? And apparently the number is greater than 60%. So apparently all comers have a recurrence rate of about 50%. If they have a normal MRI and EEG, the recurrence rate is about 30%. But if there is an abnormal MRI, prior insult, or abnormal epileptiform discharges, then they have a higher risk of recurrence. What is the median life expectancy after malignant small bowel obstruction? So after a malignant small bowel obstruction, surprisingly, the life expectancy is actually shorter than I expected. It's only 1 to 3 months. And so it should be considered a sentinel event. It should really prompt you to start thinking about goals of care with these patients, because even if they may seem okay at this very moment, apparently the life expectancy, the prognosis after having an event like this is very, very poor. And again, TPN has not been shown to improve quality of life or prolong survival. What is notable about this brain lesion? How would you describe this? This was on our recent morning report. And it's important to note that the way that this one is looking is it's ring enhancing. Not only that, but it's also kind of cystic looking as well. But there's a complete differential for ring enhancing lesions called the MAGIC mnemonic. So metastasis, autoimmune, glioblastoma, infection, and infarct, and contusion. Infections tend to have thinner and regular borders, whereas malignancy has thick and irregular borders. And so this is a useful mnemonic from GrepMed. If you are watching this, this is from Google Images from GrepMed, who has really, really great images like this. Can a pleural effusion commonly cause dyspnea while satting 100% on room air? And the answer is yes. This is due to the weight on the diaphragm, which causes dyspnea, but the lung parenchyma is intact, so they're still satting 100%. So in a problem-solving case, if somebody's satting 100% on room air, but they're very, very dyspneic, one of the things you can think about is, are they having a pleural effusion? What is a way to test for sensation in a patient who is not following commands? Again, going back to that delirious patient who is not able to communicate with you. Again, we're going to be using noxious stimuli, distal and proximal. See if they withdraw to pain. If they do, you know that they have some sensation there. What does leukoerythroblastosis on peripheral smear indicate? This basically tells you that there's immature blood cells in the peripheral blood, and this could be due to a reactive process. Your bone marrow is really trying to pump out those blood cells, or it could be due to malignancy. So malignancy or reactive etiologies. Condition in which a nerve impingement in the abdomen can cause localized abdominal pain. That's going to be this condition called ACNES, anterior cutaneous nerve entrapment syndrome. And one of the ways you can diagnose this is kind of looking at the Carnet's test, which is when you have the patient kind of do a crunch, tense up their abdominal muscles, and if the pain increases over that localized tender spot, that can be suggestive. I always like to review the Carnet's sign because I kind of forget it a lot of times, but abdominal tenderness that increases when you flex the abdominal muscles is the Carnet's sign. And a positive Carnet's sign is a sign of intra-abdominal muscle wall pain. And a negative Carnet's sign is more concerning for intra-abdominal pain. So their pain will actually decrease with flexing. Pressure ulcers that have not been debrided yet are considered what stage? So these really big pressure ulcers that have just this kind of eschar over top, this is considered unstageable until it is debrided, and then they can stage it as stage 3 or stage 4, depending on how deep it goes. PFO closure is recommended after stroke in what patients? It's patients age less than 60. Is follicular lymphoma treated aggressively? The answer is no. Remember, it's an indolent lymphoma. It falls under that non-Hodgkin's lymphoma category. And it is not as responsive to cytotoxic chemo because it is slow growing. Watch and wait strategy is generally used. Is hip thrusting, side to side head shaking, and back arching more common in psychogenic non-epileptic seizures compared to true seizures? The answer is yes. So this is going to be another helpful way for me. I had a patient with frequent PNES seizures, and it was kind of concerning. It's like, how do we tell if it's a real seizure or their PNES seizure? And other clues are that it's non-stereotyped, so it doesn't have that repetitive kind of movement characteristic. They are often prolonged, whereas true seizures tend to be less than 5 minutes. And if there's a waxing and waning velocity, variable direction, those are all more signs that it's PNES. Should you avoid Depakote in patients with thrombocytopenia or increased bleeding risk? The answer is yes, because Depakote can negatively affect your platelet function. What is the half-life of phenobarbital? This is useful in the treatment of alcohol withdrawal syndrome, and it is useful to know that it is extremely long. It's actually 100 hours, and so it really gives you a long-acting benefit in those patients with severe alcohol withdrawal, and that's why it can be so useful. Is leukemia a possible side effect of etoposide? The answer is yes, about 5% risk of developing it within 4 to 7 years after therapy. Is cardiac monitoring on discharge recommended for stroke workup, even if it looks like a large vessel occlusion rather than a cardioembolic stroke from, for example, AFib? The answer is yes. So per Neurology, they said up to 28 days, even if it looks like a large vessel or small vessel etiology, just always get that cardiac monitoring on. Seizures usually last less than how long? Less than 5 minutes. And convulsive syncope after vasovagal event, for example, usually lasts less than 30 seconds. What type of ischemic stroke is a candidate for thrombectomy? So you've got those 5 types of strokes. You've got large vessel occlusion, you've got your small vessel ischemic disease, you got cardioembolic, then you've got like cryptogenic, and then there's one more that I'm missing. So large vessel occlusion is going to be the one. And the 3 main large vessels are going to be left MCA, right MCA, and basilar artery. A patient recently started on dialysis and started on a new antihypertensive, develops a rash, pancytopenia, and pan-positive immunologic workup. C-ANCA is positive, P-ANCA is positive, ANA is positive, anti-Smith, anti-dsDNA is positive. So think about drug-induced lupus. This one's also going to have the antihistone antibody, which is definitely characteristic of drug-induced lupus, and this is from hydralazine. What cell lines might be elevated on the differential in a patient with CML? Again, this is going to be all those kind of mature cells like the metamyelocytes, myelocytes, promyelocytes, and monocytes. And you may or may not have blasts as opposed to AML, which will always have blasts. Can a focal seizure present with just the feeling of fear or panic? The answer is yes. And this is something that was interesting to me. I actually did not know this. Typically, that's going to be the ones that are involving your temporal lobe. So you can get emotional fear, déjà vu, jamais vu, which is familiar things suddenly feeling completely new, complex hallucinations, olfactory, gustatory hallucinations, can also happen in your parietal and occipital lobes as well. How long should a patient be on DAPT for after a cryptogenic stroke with a low NIHSS stroke score? That would be 21 days, and then you switch to that Plavix monotherapy that we talked about earlier. Is 21 days of DAPT recommended after cryptogenic stroke with high or low NIH stroke scale? So low is recommended. So the reason is because there's a risk of hemorrhagic conversion if it's a high NIH stroke scale stroke. So only in these lower risk strokes do we do the DAPT. Otherwise, we just do monotherapy. What is the main reason for placing an NG tube in patients with bowel obstruction? It prevents complications. So it's not to cause the bowels to untwist, although there is a thought that it may help in that regard. But really, the main reason we place the NG tube is to prevent aspiration, which is the big complication in these patients. The decompressing the bowels to allow it to untwist is possible, but it hasn't really been proven in studies. Convulsions following vasovagal syncope usually last less than how long? That's going to be 30 seconds, as we mentioned earlier. What two regions of the lung does pulmonary TB often present in? So most people, at least for me, knows that reactivation of TB tends to present in the upper lobes, but you should also know that there's specific regions that are characteristic of TB. So the posterior and apical upper lobe, and also the superior lower lobe is also a frequent place for reactivated pulmonary TB to present. Is someone with only a few seizures a year considered well-controlled epilepsy? The answer is no. Well-controlled means seizure-free. And this is important because it has driving, employment, and social consequences. There's cognitive decline with ongoing seizures. Depressions and suicide are more common in epilepsy patients. So the absolute goal is to be completely seizure-free. And 2/3 of people are able to become seizure-free with either the first or second drug. Why might a SNF prefer to take a patient on comfort care rather than hospice? Now, this situation came up where we were discharging a patient on hospice. SNF said, we don't have a hospice bed, but we do have a bed for comfort care. And our case management let us kind of know that this was kind of ethically questionable. And the reason is because potentially they were trying to bill Medicare, which they could on comfort care, whereas they could not on hospice. I don't know the logistics of this, but it definitely made a big issue for getting this patient to a safe place after discharge. A patient on comfort care has way less support than a patient on hospice, where there's going to be hospice nurses, physician, a lot of ancillary staff that's coming very frequently to adjust their medications, adjust their pain meds. Comfort care, really, they're not going to get any special care. There's not going to have extra people that are there to support them. So this was a big issue for a patient who really did need that hospice level of care. In a severely dilated colon, what has usually occurred before the bowel perforates? The answer to that is ischemia. So dilation causes pressure on the venous outflow, leading to ischemia. This leads to weak tissue, and that finally leads to perforation. So when surgeons open up the abdomen in these cases, they never see healthy tissue, but they usually see dusky and necrotic tissue, which is why it perforates. What is a good way to address a patient actively having a psychogenic non-epileptic seizure? So some of the things is to just reassure them that they are safe, that seizures typically end around 5 minutes. So one way that the neurologist recommended is say, letting the patient know that seizures usually end around 5 minutes. You're currently at X minutes, so it should be ending soon. What process can explain why cancer can lead to lactic acidosis? This is the Warburg effect, and this is because cancer loves glycolysis, which causes more metabolism of pyruvate into lactate. Is 21 days of DAPT recommended for TIA in patients with a high ABCD2 score or a low ABCD2 score? This is the risk stratification for TIA, and opposite of strokes. In this case, we actually want to give the DAPT to the patients with high ABCD2 scores, whereas in those stroke patients, we wanted to give it in the low NIH stroke scale scores. Syndrome causing persistent watery diarrhea that is unresponsive to antibiotics. That is Brainerd diarrhea. This is just a random fact that I learned in the clinical problem solving episodes. The cause remains unknown, but it has been associated with raw milk and untreated water consumption. What can atypical lymphocytes on blood smears suggest? So if you ever see atypical lymphocytes, you should definitely think of a viral infection, especially like EBV, CMV, or you can think of malignancies such as leukemias. So lymphoma, leukemia, and viral infections. What is a good tip to differentiate aphasia from confusion? So again, this happens very commonly in our altered, delirious patients. You can't tell if they are just unable to speak, which would be concerning for a stroke, or if they're just confused, so they're not really responding to you correctly. Really, you just got to be very aggressive. be yelling in the room. Really just try your hardest to ask them to name common objects and just, really push it as much as possible to try to really figure out if it's aphasia or if they're just a little bit confused. Is tumor lysis syndrome common with Hodgkin's lymphoma? Actually, with Hodgkin's lymphoma, tumor lysis syndrome is not common. And actually, per one of our morning reports, you don't even need to trend tumor lysis syndrome labs for patients with Hodgkin's lymphoma. Now, are we actually going to do that in practice? I feel like most people are still going to be trending TLS labs. But I actually looked it up, and it is very uncommon with Hodgkin's lymphoma compared to other lymphomas and leukemias. What is one of the earliest signs of intra-abdominal sepsis after an abdominal surgery? So per the surgeon that gave us a talk, tachypnea is one of the earliest signs that they often see that can lead them to be suspicious of some kind of intra-abdominal process going on. How much volume of brain involvement is required to detect a seizure on EEG? I've had a card on this before, but it's 6 cubic centimeters or 6 milliliters, whatever you want to use. And so a negative EEG, therefore, does not exclude the diagnosis of epilepsy, because if there's a smaller amount of area being involved, you may not even be able to see it. Should you hold off on antibiotics in a patient with suspected vertebral osteomyelitis if they are clinically stable? The answer is yes. This is to help increase the biopsy and culture yield. And should you be aggressive with benzodiazepine dosing up front for seizure treatment? Again, this is yes. So there is evidence that decreased benzodiazepine dosing leads to more intubation and respiratory depression. 4 milligrams of Ativan is generally a good starting point. It is weight-based if you actually look at the guidelines, but 4 milligrams is going to be probably sufficient for most people because that's kind of the max dose that we give. And most people are, over the weight that we would be considering giving a lower dose for. Could you still need dialysis for a patient with concern for lithium neurotoxicity, even if serum lithium levels are low? And the answer to this is actually yes. So the serum levels of lithium don't necessarily reflect CSF levels. So even if your serum levels are normal, you may still have toxic levels in the CSF causing altered mental status. Definitely a nice learning point for me, which I did not know before. What is the new term for focal onset aware seizures? So they keep changing this again and again, like I mentioned earlier, but now it is focal onset preserved consciousness and focal onset impaired consciousness. And so now, it used to be impaired awareness and focal onset aware, but I don't know, they just keep changing it, but it's good to know what the updated terminology is. How long should a patient with stroke due to intracranial atherosclerotic disease be on dual antiplatelet therapy for? That would be 90 days or 3 months. How long should you wait before deciding to treat a seizure with a benzodiazepine? So the threshold for treating is going to be 5 minutes. So if a seizure is going on for less than 5 minutes, it's likely to stop on its own before the 5 minutes is up. And so no need for medications, as this may increase the risk of respiratory depression. But greater than 5 minutes, you're starting to get into the definition of status epilepticus, and you should start giving a benzodiazepine. What is the second port on an NG tube called, and why is it needed? So it's called a sump port. And the reason it's there is because if you just had an NG tube that was just one port, one problem with that is that it could just get sucked onto the gastric wall, start causing trauma and irritation in that area. The sump port allows an alternative route for air to enter and kind of release that tension so it's not just stuck onto one spot. Another thing that I learned is that, we do intermittent low wall suction if you don't have a sump port, because if it is sucking onto the gastric wall, releasing that suction is going to help it release from the gastric wall. And then you put the suction back on, it's not going to suck onto the same spot. But if you have a sump port, then you can do continuous low wall suction. What is the official terminology for pressure ulcers? That would be pressure-induced skin and soft tissue injury. Again, just useful to know the official terminology. Why is a patient with a bowel obstruction and a malfunctioning NG tube potentially at the highest risk for complications? The reason is because they have an even higher risk of aspiration than they would otherwise have at baseline, because now they have an NG tube that is stenting open their lower esophageal sphincter and it's not functioning, so they are going to be an aspiration risk, and now it's even worse because that sphincter is stented open. What is a veterinary sedative that is now being used as an illicit drug? This one, I believe, is called xylazine, often called tranq colloquially. Causes sedation, hypotension, bradycardia, respiratory depression, and there is no approved reversal agent. It can give very bad skin wounds and also causes a withdrawal syndrome as well. Is it essentially required to have ascites in order to have hepatorenal syndrome? So yes, it is very rare to have HRS without concomitant ascites. Is it safe to place an NG tube in a patient with esophageal varices? This comes up very frequently. And the answer is yes. So there is definitely a bunch of mixed thoughts on this, but it is generally considered safe. There are multiple reviews and meta-analyses that concluded that you cannot make a strong statement that placement is absolutely safe, but you can also not say that there is a significant risk of inducing a bleed. So basically, it's kind of a wash. So the recommendation was that if there's a strong indication to place an NG tube, then do not delay placement due to hesitancy about varices. One specific scenario that we do want to avoid placing an NG tube is directly after variceal band ligation. Typically, we will hold off on placing that for 48 hours after the procedure. Does acute lithium toxicity or chronic lithium toxicity tend to present with more neurologic symptoms? And that's going to be chronic lithium toxicity. Acute lithium toxicity tends to cause more GI symptoms because it takes some time for lithium to cross the CSF. So that's why chronic lithium toxicity is when you're going to start seeing those neurologic symptoms. Can naltrexone be started in patients with cirrhosis or an AST/ALT greater than 5x the upper limit of normal? Apparently, the answer is yes, which is surprising because if it's greater than 5 times the upper limit of normal, I might be a little bit hesitant to start naltrexone. But apparently, recent studies have shown that it is safe to start. This was an old black box warning that was telling us to avoid in patients with elevated liver enzymes. So definitely something to consider even in these patients with liver damage. What 2 classes of medications should you stop immediately if concerned for hepatorenal syndrome? That would be diuretics and beta blockers because they're going to worsen the physiology that's leading to HRS. Is spasm control important in the management of patients with chronic pressure ulcers? The answer is yes. So per one of our plastic surgeons, you need to control spasms in order to optimize for flap reconstruction. Baclofen is often first line, and PM&R eventually gets involved if the patient needs a baclofen pump. What is a way to assess visual fields in a patient who is not following commands? This is just doing that quick blink to threat. And if you do that and they blink their eyes when you suddenly move your fingers at them, then that tells you that the visual field is intact. What is the best imaging test for assessing for stroke that occurred over 24 hours ago? So say you suspect a subacute stroke and you know that there's no role for TPA or thrombectomy because it's been a long time since the symptoms came on. What would be the best test? So apparently it's an MRI brain without contrast and an MR angiogram without contrast. MRI with contrast is only needed if looking for tumor, and the MRA doesn't use contrast as it uses something called time of flight instead. Altered mental status with intact arousal is more concerning for what etiology in the MIST mnemonic? So the Clinical Problem Solvers has this great altered mental status mnemonic of metabolic, infectious, structural, and toxins. And so if the arousal is completely intact, then you're going to be more concerned for structural causes, because the reason they're possibly altered is because of a focal neurologic deficit that's affecting their speech or comprehension or something like that. But if somebody has depressed level of consciousness, it's more likely a systemic issue, metabolic things, infections, and toxins. Those can kind of cause a lower level of consciousness. If a patient fails Lovenox and has recurrent DVT, what are 2 options moving forward? You can either switch to a DOAC or increase Lovenox dose by 20%. What is the medication used to treat Ogilvie syndrome? That would be neostigmine. Watch out for the side effect of bradycardia. Patients should be on telemetry and have atropine at bedside. And the next step is often colonoscopy for decompression. Don't forget to also replace potassium in these patients to help get the bowel moving. Can intravesicular BCG lead to spread of non-TB mycobacterial infection? The answer is yes. So this is definitely rare, but the BCG is made with an attenuated strain of Mycobacterium bovis. And this was an interesting case on Clinical Problem Solvers in which a patient who had bladder cancer received intravesicular BCG and then eventually was found to have this widely disseminated mycobacterial infection. And the original source was from this intravesicular BCG he received. What is the proper term when you have a seizure with increased tone followed by clonus throughout, but no EEG data? So the mistake in terminology people use here is calling it a generalized tonic-clonic seizure, but you don't know if it was generalized tonic-clonic until you have an EEG. So they recommended just calling it a convulsion or a bilateral tonic-clonic seizure until you have EEG data. Is it common to have both epilepsy and psychogenic non-epileptic seizures? The answer is yes. So up to 30% of people with epilepsy will also have a functional neurologic disorder. And I think this makes sense because of just the amount of psychosocial stress that having epilepsy causes on somebody. We talked about it earlier. It could very easily lead to a functional neurologic disorder like PNES as well. During a gastrographin challenge, should you have a low threshold to put patients back on suction if they have nausea? The answer is yes. So when patients have small bowel obstruction, one of the things that we will do is a gastrographin challenge, basically giving them contrast, then taking another x-ray in about 8 hours and then potentially at 24 hours to see if the contrast has gone past the obstruction. And if you see it in the rectum, you know that their obstruction has resolved. The problem is gastrographin actually has a pretty high aspiration risk, and it can cause a very bad kind of pneumonitis picture. So if they have any sort of nausea going on, just abort the challenge and just put them back on suction from their NG tube. Decrease in what cell function increases the risk for PJP? So that's going to be your T cells. Can convulsive syncope still have tongue biting and urinary incontinence? Generally we think about tongue biting and urinary incontinence being more associated with a true seizure, but convulsive syncope can definitely still have all of these features as well. What kind of therapy is trastuzumab deruxtecan? This was an interesting learning session that we had when I was on the HEMONC service, but basically these are antibody drug conjugates. And so basically, it's a really cool mechanism of how they work. You have a monoclonal antibody against HER2, and you attach a payload of chemo. Theoretically, this will decrease the risk of systemic effects, although you definitely still see a lot of systemic toxicity as well with any sort of chemo, pretty much. One of the significant side effects is interstitial lung disease. All right, and that is it for all of the learning pearls that I learned over the last month. Hopefully there were some things that were useful in there for you. Hopefully it's interesting for you guys to just see, again, my process of keeping track of all the pearls that I learned throughout the course of being on service. Let me know in the comments if you want me to continue doing videos like this. Thanks again for watching, and I'll see you in the next video. Peace.